Thank you, Hilarious. Thank you, Dr. Nirmal, for giving us this opportunity and have this discussion. So I'll be talking about hospital infection control standard overview regarding accreditation. So this topic will be more relevant to hospitals who are already having NABH accreditation or are in process of getting one. For others who are not in this process, you can understand all the good practices which we are going to discuss and incorporate into your practice. Because bulk of my talk is regarding documentation of what we are going to do in COVID times, and it's going to help any hospital in case things go wrong. Let's say, even if it's a small practice, God forbid something goes wrong, government, medical, legally, all the records are going to be asked for, and these are the ones which are going to save you. So please take care of these things in your practice. So as an assessor, right now the process of NABH accreditation is stuck, so everything is postponed. But once things go back to being normal, or let's say the travel is started, so there will be pre-assessment, assessment, surveillance, reassessment, and entry-level certification. These are all which are going to take place. And in those times, the assessors are going to visit your hospital. So when we are going to visit your hospital, what are we going to ask for regarding COVID? That's the emphasis in this talk. So what Dr. Nirmal discussed, hospital infection control and prevention, HIC full chapter, what is there is to be discussed. So if we are visiting you, we are going to ask your compliance regarding that, with particular emphasis to what you did during COVID times. There has a element for occupational safety, whereby the staff working in hospital is safe, which will include providing them PPE, training who needs PPE, and monitoring whether it's being done or not. Patient safety will be covered in facility management service chapter, which talks about keeping the hospital safe, and Dr. Nirmal gave you an overview about cleaning and maintaining the hospital, which will be also discussed in subsequent talks. The consent by the patient. So we need to have modified consent now, right, for emergency services, for surgery, and even for OPD examination. So that needs to be taken care of. And lots of things coming from government, as Dr. Rajesh told, we don't know what's the right hand doesn't know about the left hand. So we have to comply to all local, state, union government orders and directives. And AIS is keeping us abreast, and we are also getting regular notifications from our state societies and IMA. So locally, wherever you are, we'll have to comply with whatever directives come in. So I'm just going to enumerate the situations where we need to have, where I would like to, need your attention. The details of all certain things which I'm going to mention are being discussed in the subsequent talks. So the first important step right now would be to have a hospital infection control committee. It's a multidisciplinary committee, and it can consist of hospital administrator, microbiologist, infection control specialist, ophthalmologist, nursing staff, supervisor, CSSD in charge, OT in charge, infection control officer, infection control nurse. This is a list for a big hospital. The numbers can fluctuate. If it's a small hospital, it could be a smaller list. So based on whosoever is handling the activities in your hospital, you need to make a committee. So if you have not made a committee, whatever people you are like, it's a group who's doing things, document that and formulate a committee. So once your hospital infection committee is there, the committee needs to meet and monitor the compliance to measure what we have discussed. So normally the hospital infection control committee meets once a month. Due to COVID now, the meeting frequency can be increased. The committee could meet as frequently as a week or even less to take care of what's happening. So your infection control committee meetings will be much more frequent, needs to be documented. You can have additional people joining the meeting as per need. So whosoever is responsible, whomsoever you feel is required for the meeting should be part of the meeting. Now, all the areas are divided into high risk, moderate risk, and low risk. Due to COVID, even the low risk and moderate risk areas can become high risk areas. So certain low risk areas are now considered moderate because of COVID infection. So you'll have to again redesignate the areas in your hospital. Earlier something which was low risk, right now might be moderate risk. And the infection control committee will devise and communicate to everyone in the hospital what protocols you are going to follow. So you make the protocols which are going to be implemented in your hospital. Someone has to see that has been done. That will be part of infection control committee, and particularly infection control officer and infection control nurse who are going to drive this all activities across the hospital. They will have people helping them out, and they are the primary people. So infection control nurse and infection control officer are going to be the actual people who are going to do things and report back to HIC and see what's happening on ground. So these are things that for moderate to big size hospital. For small size hospital, there will be all overlap. So let's say the infection control officer could be you yourself, and you will be the person who's driving all the things. So you can think of these things as per need. So other important thing right now would be PPE. So most importantly, what you have to see is whether it's available to you or not. Everyone is finding it difficult. Cost is more, supplies are not there. So as a hospital, that's a big amount of planning now, that how much PPE you need, from where you are going to procure and how you're going to use. And very strict instructions are there for use of PPE, because if you don't use them properly, they don't help. And equally important is the disposal of PPE after use. So what consists of PPE, the donning and doffing, is going to be discussed by Dr. Rajiv. So in his talk, he'll cover that. You may need to have arrangement of isolation and quarantine facility in case your hospital is part of, let's say, a big multi-specialty hospital or affiliated to a hospital who's already dealing with corona patients, medical colleges. So even for eye department, since you are going to provide limited service, there could be some amount of exposure. So there has to be an arrangement for quarantine of people who are on duty dealing with corona patients, or isolation if required. Even for smaller hospitals, there has to be some plan in place that, okay, if things go wrong for your place, what are you going to do? It's just to prepare for emergencies and have it on paper. So whatever I've discussed till now, these are the things which we need to put it on paper in writing, so that, let's say, if 3 months down the line, if we question, or someone questions me that what did you do for corona, what measures did you take in place, your memory is not going to be good enough. So whatever we are doing, we document them in our own simple way. It's okay, there's no particular thing, but 3 months down the line, I should have a process of showing what we did. So just to put in process now, we have a grocery shop right next to my home where we can walk and get our groceries. It's open now, it has got license to open. That shopkeeper is diligently making everyone wash hands or use hand rub. And he has got a register there where you have to give your phone number and name. He needs phone numbers of everyone who has visited. That's a government guideline. It is very diligent about it. People may give wrong phone number, that's a different story. Same with us. So at that level, if people can document things, we also need to document. Tomorrow, if something goes wrong, you need to have all this document pulled and see where and how things were. So let's say you got some PPE and tomorrow there is something wrong with those PPEs. How will you know whether they have to be used or not? You have to be documented, who got from where and everything. So the traceability of quite a bit of things need to be there. Hand hygiene is probably the most important practice what we need. And the WHO guidelines and videos are a good reference for you to teach them to the staff. You can give them the videos, they can have it in their mobile, they can watch the videos to understand how to be done. And most importantly, everyone has to do it. That's where everyone has to become part of the movement. So if one of 100 people is not doing hand hygiene, the people around him have to mention that, you know, it's a good practice, we have to take care. And I've given the WHO link, you can even Google up and get information about this. It's a free download, no copyright. So most important thing is, when do you wash your hands or when do you use a hand rub? So that is before touching a patient. That is before touching a patient or after touching a patient, and especially after procedures or everything is done. So very important to have this thing drilled. It should become a habit. By default, you should, or your staff and everyone is washing hands or using a hand rub, need not be reminded to anyone. So these are the steps of hand rub. There are certain areas which you normally miss. If you just put stellium or something and just rub your hands, this is a proper way. This has to be drilled and displayed all across your OPDs and OT wherever you want them involved, that follow these steps. These are the proper steps to maintain proper disinfection of hands. And in case you are using soap and water, the process is still there. So these posters are good. Share it with everyone. Free downloads from WHO website. So biomedical waste handling also becomes difficult now. It includes even the mask and PPE. So as per the current instructions given by government, we have to use double layered yellow bag with COVID labeling and separate record for biomedical waste disposal. Dr. Chandrasekhar will discuss details with you. These guidelines may change as far as things go in future, but you'll come to know of it as it's communicated. Now, disinfection activities, sodium hypochlorite is the best media to be used. It's cheap, it can be made, that's the cheapest available to us, and it's highly effective. So you need to increase the mopping of moderate and high risk areas. So they are cleaned very frequently. High risk areas every 2 hours, moderate risk areas 3 times a day at least. All the places where patients are touching door handles, let's say side rails on stairs, bed rails, all reception counters have to be cleaned with sodium hypochlorite or can be used with alcohol wipe. Alcohol would be the second best media to use considering availability and the cost. All the chairs, all computers, everything where the touch is happening need to be cleaned with alcohol swab now. Earlier we may or may not be doing this. Stretcher, wheelchair, anything which comes in contact with patient again should be cleaned with 1% sodium hypochlorite solution immediately after the stretcher has been used, and fogging of hospital on a weekly basis. There are more guidelines regarding cleaning which is going to be discussed by Dr. Kumran, but these are basic. Hypochlorite is something which I think so is very, very important now. And what problem I have faced in hypochlorite is it's the job given to some of the staff to do and use it. So it could be your housekeeping staff, in particular some of your OT staff. And hypochlorite is available in different forms. So how you're going to reconstitute it is very important. It's not all the same. So when I have asked personally, how do you do that? Someone has one measure, like I'll put 2 caps of this is a liquid, or I'll just pour it like this, or this is enough in one big bucket. They don't measure the volume of water. They don't measure the volume of chlorine hypochlorite being added. So you need to get them a very simple measure that, how much is water and how much is the powder or the liquid, and it has to be reconstituted in a proper way. So this whole chart is just to demonstrate. So you see what you're buying. If it's a liquid, you add 1 part of bleach to 4 parts of water. So you can have a same container, take 4 measures of it and add 1 measure of bleach. So this has to be prepared fresh and used fresh. It's not that we make it and store it and then use it again. So that will really not give you good result what you want. So proper mixing, fresh solution to be used every time possible. Staff protection, the biggest thing is one staff can endanger everyone. It could be the entire his colleagues and the staff in hospital, patients and all other people who are visiting. So we have to make sure that everyone is following the SOP. So for doing that, you have to first tell very clearly to every level of staff what they are supposed to do. Tell them that this is what you have to do and this is non-negotiable. This is the protocol which is in place. Now, after doing that, you'll have to train them to use many of these things. Many of the workers whom we are asking to use PPE now, asking to do certain things, have not done that. They don't have the comprehension level, probably they don't have the training level. So we have to be very patient, make sure that we train each and every one. People have to be, we have to monitor the compliance. We have to make champions in your entire hospital, people who are going to make sure that things are being followed and every deviation has to be sorted immediately. There is no way that you keep sitting on that. And there will be lots of retraining. The protocols may change and you need to reinforce everything. So right now, these all trainings have to be repeated again and again and make sure that we attain best possible compliance. There has to be also an NABH standard which will deal with patient education and communication. We call it external reporting. So now you have to, as a public measure and as per NABH requirement, have some patient education regarding COVID. You could put it on your website. You could have something displayed in a hospital. You could have some handouts. You may like to send out some emailers to your patient. It's all up to you. You may have to educate patients regarding COVID. That's our social duty, as well as NABH might have to ask you in one particular standard that how that was done. You have to educate patient regarding hand hygiene, social distancing. All these things can be done, documented as a part of our social duty and patient education. We have to also give information to patients because practices are not open, how we are dealing with them. So they need to be informed regarding what is available, what is not, how our OPDs are going to function, how are the appointments being given, what way they can still attain urgent care or emergency services from us, what is the status of teleconsultation facilities in your hospital or video consultation. All this information has to be given to the patients and documented under external reporting, that how did we report these things to the patient externally. Visitor restriction and regulation has to be put place in the hospital. We have to maintain social distancing in our waiting areas. We can and we should regulate the number of patient attenders who visit with them. We should probably and preferably stop all non-patient visitors to the hospital. A daily list of all healthcare workers, patient attenders, anyone coming to the hospital should be maintained along with verified mobile number, and probably if you want an ID proof if that has been asked for by your local government, for contact tracing if required in future. So if something goes wrong, we should also have all our duty rosters available, that who was present on a particular day, he was on leave or not. So HR really has to work sure and make sure that you can trace employees and you can trace their contacts if required. Very important right now is prioritization of service. Good for us is that IGO came up with lots of things yesterday. So I've just compressed it to one slide. Have your triage policy in place. The good referral would be the Indian IGO article, which has consensus statement on preferred practices during COVID-19 pandemic. All of us have received in our email yesterday. A nicely written article will answer lots of questions, and I would say it makes a good reading today. And just to see, one of the things which we felt initially was conjunctivitis patient. So Narayan Netralia did make a protocol for dealing with conjunctivitis patient, which again is in IGO, this issue, what ophthalmologists should do in case, should know about conjunctivitis in COVID-19 protocol. So that article also is a good read. In fact, the entire IGO issue is a good read, and we have Dr. Namta Sharma, Dr. Rajesh, and Dr. Maipal, who are also part of the practice patterns and who have helped this issue to come, to thank for that. And very important is what you do with emergency patient. We do come to across that small practices do say that we don't have emergency, and ours is a small practice, we don't deal with emergency patient. One important factor is the patients whom you have treated before. Your follow-up patients may have emergency problem. They still are looking for some help. So that's something I believe again needs to be planned. And you may need to just guide them to a nearest place, but that's what patient need. They need some help regarding attaining emergency care. Thank you. That will end my presentation. Thanks for patient listening and time.